Hey guys, hello, namaste. So myself, Dr. AJ Maurya. So guys, I am also like you only. Okay, I too don't know anything. I am not a professor too. Just, just share. I'm just sharing what I know, which are important for the exams. Okay, because yeah. See, okay, guys. So today, let's discuss. Let's continue our discussion. We're going to discuss our part 7. Okay, try to cover our all the important cover all important questions by me. Part 6, 7, 4, 5, 1, 2. Every parts you have to complete. Okay, now. So you can also. I also know Telugu. I know Telugu, Tamil, Hindi, Bhojpuri. Everything I know. ఓకే. ఎనకు తమిళ్ తెలియదా? తమిళ్ తెలుసు, హిందీ తెలుసు, తెలుగు ఓకే. ఐ నో. ఫ్రెండ్స్, లెట్స్ బి ఫ్రెండ్స్ అండ్ డిస్కస్. ఓకే. ఓకే గైస్. సో గైస్, see, I have my own PDF that is which covers 150 plus topics. Okay. So if you want to cover all the topics, then you can download this PDF. The link in the description, or you can just search in Telegram. You will get it. Okay. So there are many important things related to surgery also, which I didn't include it here, but it is in that PDF. You can go ahead. You can go and study there. Okay. Okay. Here the first question. రెడీయా? ఏ తమ్ముడు, రెడీయా? స్టార్ట్ చేద్దామా మామ? కరే. ఓకే. ఫస్ట్ క్వశ్చన్ ఫస్ట్ క్వశ్చన్ ఫస్ట్ క్వశ్చన్ ఓకే. సీడా ఫస్ట్ క్వశ్చన్. A lesion in the VPL nucleus of thalamus will mostly causes loss of. Oh, see, VPL nucleus. See, I will tell you one thing. So these are the thalamic nucleus. Thalamic nucleus. See, this is your lateral geniculate body. It's controlled by what? Light, like visions, for vision. For MGB means medial geniculate body, for hearing. How you are going to remember this one? See, LGB, remember light. Light means vision only. For vision, LGB. M for music. Music, M for music, hearing. VPM, ventro-posterior, here ventro-posterior medial. This is a medial. This is medial nucleus. What medial side? See, this is what face sensation. Face sensation medially. Face sensation medially, and taste also. This is by your VPM. This is by your VPM. Just remember VPM medially is face sensation, and lateral everything is by your VPL. Okay, just see here. Vision is by your LGB, hearing by your MGB, pain memory is by your what pepper circuit, and pain and temperature from body is by your VPL nucleus. Okay, this is the answer. Okay, next one. A 65-year-old man suddenly developed violent flinging movement. Flinging movement means it is your hemibalismus. Your hemibalismus, and hemibalismus. What is the site of what is site of the infarct here? Is must be your subthalamic nucleus. So I will be coming here. Okay, na subthalamic nucleus. Next one, which receptor is primarily responsible for the directing vibration of high frequency is going to your Pacinian corpuscles. Okay, na. So this is my notes actually. So I will teach you how to remember this one. Okay, Canada. Okay, see here. Tactile receptors, we are having two types. We are having the rapidly adapting, slow adapting. Rapidly adapting, slow adapting. What is rapidly adapting? Tell me. Suppose example, she is my girlfriend. She is my girlfriend. Okay, now we became couples like yesterday only. So okay, so we went for dating. I just hold my girlfriend hand. So by that time, guys, I'll feel very excited, full emotional. Okay, see, by the time passes after 1 year. Again, when I'm going to touch my girlfriend hand, will it give me excitement? No. That is your rapidly adapting. It is a fake love. Okay. Next one is your slow adapting, meaning it is a true love. Got it? So rapid adapting, remember, pack my hair. See, pack my hair, mnemonic pack. P for Pacinian corpuscle, M for Messner's corpuscle, H for your hair and organs. See, Pacinian corpuscles, remember Pacific Ocean. Remember Pacific Ocean. Pacific Ocean is very deep. Okay, na? And the water will be move like a vibration. Gives the water movement, gives the vibrations. So, which is the most rapidly adapting is going to be your Pacinian corpuscles and gives further deep pressure and stimulated by your vibrations, high frequency vibrations. Okay, na? Next one, Messner's corpuscle. See, Messner's, miss means my girlfriend. My girlfriend. Miss means girlfriend. Means girl. Girls don't have hair. So it is moving touch by on the water at a non-hairy part. Okay, na? Non-hairy part. Okay. Next one, hair and organ means on the hairy part. Okay. Next one, Merkel disc. Merkel means what? See, it's a point touch. It is a point touch, and two for the bottom for the 2 point discrimination. Okay, this is the edges. This is the two. This is the 2 point discrimination. Okay, na? Next one, roughly, rough. See, rough sizes. It will tell the size and shape of the object, and it's a stretching skin. See, okay, this is okay. This is the this is I think this is a rectangular shape. Okay, this is the coin like this one. Got it? Next one. Okay, next one. Now fibers classification. We are having three types of fibers: A, B, C. A, B, C. Okay, so A having alpha, beta, gamma, delta. Okay, now I think you guys already know this one, but still I'm teaching because I'm teaching only on high yield points. Okay, now see, they will ask you which is the fast and sharp pain. It's going to your delta. Delta is your fast and sharp pain. Okay, na? Next one they will ask you which is a preganglionic. Remember BP type B fibers your preganglionic, which is for pain and temperature. Pain and temperature was a warm type, and a post ganglionic is going to your C type. Got it? Which receptor, which fiber is for the pressure and touch? See, beta, touch mat karna. Beta, B, touch mat karna. Touch and pressure. Okay, na? Beta means what? Sun. Listen, hey, don't touch my son. Like this, see, beta means sun. So don't touch means touch and pressure for the beta. Got it? Remember this one. Next one, here. Cited lesions and the disorders. Parkinson disease is a universal fact. Everyone this know. Substantia nigra. Hemibalismus. Everyone know this one. See, hemibalismus. Remember, balis. Balthal. Just remember Balthal. Balisthal. This is going to a subthalamic nucleus. Remember, flinging movement is associated with the hemibalismus. Next one is your Huntington chorea. Huntington's chorea it is your where amma at a putamen at your putamen. Okay, na putamen. Next one, ethitosis. Remember ethitosis is region at a globus pallidus. Remember AG Sunina. See. AG, Sunina. See, AG ethitosis, G means global pallidus. Okay. Next one. This is the your hypothalamic nucleus. Remember the mnemonic SOAP. Supraoptic. This is ADH. Oxytocin is your paraventricle. Okay. Just remember at least these two hypothalamic nucleus. Next question, we are coming here about the heme synthesis. See, heme synthesis is very important points for, regarding the exam ra. Okay, na? Just remember, just listen my words for the 5 minutes. Okay, na? See the what questions they will ask you here. Remember the first question they will ask you, what is the substrate for the heme synthesis? Tell me. It is your glycine and a succinyl CoA. Succinyl CoA is coming from where, amma? At the your Krebs cycle. Next question. First question is one. Next question. What is the amino acid required for the heme synthesis? Is going to your what? Glycine. Next one. What is the rate limiting step? It is your ALS synthesis. Next question. Heme synthesis occurs in both mitochondria and your cytoplasm. Got it? Okay, na? Okay. Can you tell me? Can you comment below? Okay, now what are the other pathways that occurs in both mitochondria and cytoplasm? Just comment below. Okay. Okay. These are the 4 questions from the heme synthesis. Okay. Now? And the next question, guys, you have to remember. You have to remember. See these 2 conditions. The first condition is the you are remember read this one. Adult female present with recurrent episodes of abdominal abdominal pain, nausea, constipation, tachycardia, hypertension, peripheral neuropathy, urine darkens on standing. Remember, whenever you see the urine darkens on standing, remember this is the case of AIP. It is your acute intermittent porphyria. So, what is the accumulation? See, what happens? See, this is the case whenever there is a deficiency of this uroporphinogen synthase or uroporphinogen deaminase enzyme deficiency. What happens? There is accumulation of your porphobilinogen. Okay, there is accumulation of porphobilinogen. Okay, now. So this is the case of your acute intermittent porphyria. Okay, now you have to remember. See, dark color in AIP, dark color AIP. So this is the case of your atoma. What is your congenital erythropoietic porphyria? Congenital erythropoietic porphyria. Okay, now just remember this case and also remember by the given history you have to know whether it is a whether it is what type of whether it is this type of porphyria or not. Remember, if the question says that patient present with neuropsychiatric manifestation then you have to go with what your ALA dehydration deficiency porphyria or AIP. So here we are seeing the is there anything is so in this question is there any neuropsychiatric conditions? Tell me here. Pain, nausea, constipation, tachycardia, hypertension, peripheral neuropathy. No, it's not there. Oh my goodness, question is not mentioned already. Okay, na? See, however, guys, wherever there is a neuropsychiatric, okay, na? Hey, there na, neuro is there na, peripheral neuropathy. What are you? You cockroach Chanta party. Okay, see, peripheral neuropathy, it is a neuropsychiatric, it is a neuro problem. So, it is a AIP. What are the things associated with the photosensitivity? It is your congenital erythropoietic porphyria. Okay, porphyria and your PCT porphyria carditis and erythropoietic photoporphyria. See, remember, see this is your congenital. See the question. This says that it is severe photosensitivity. Okay, na? If the questions if they don't mention the photosensitivity, then you have to look at these options. Okay, na? If it is photosensitivity, then you have to include look at for these three conditions, or else just rule out this one. Which is present with both. It is your hereditary coproporphyria and variegate porphyria. Got it? Okay, now done. Just remember at least this points, and also remember where does lead act? Lead is going to inhibit this reaction. Lead is going to inhibit this enzyme, that is ferrochelatase, and also it also inhibited the what ALA dehydratase. Okay, now just remember these conditions for the exam point of purpose. Okay, got it? Next one. See, remember, okay, na? See, these are the very easy one, ra. Or they will ask you, okay, what is the secondary messenger? Okay, now, what is the hormones? What type? See, they ask you, see, this is your, they given the aquaporin. Don't read the full question. Just see what they asked. They asked about the aquaporin. What is the, which intercellular secondary messenger? See, aquaporin, okay na? See, aquaporin is going to be your cyclic AMP. Cyclic AMP. Remember one thing, if there is aquaporin 1, remember there is aquaporin 1, V1. V1, remember it is a IPG. Remember it is a IPG. 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 How, see, aquaporin 1 is resembles as I. So V1 IPG. V2 cyclic MP. So okay, cyclic MP, cycle. We have in the cycle 2 wheels, 2 MP. Got it? So this is the first question. The next question that they will ask you, the most important one, they multiple times asking, they will ask you only about the cyclic MP. How you are going to remember this one? Remember it is a flat. This is your flat HCG. Flat camp. Remember, sir, flat camp. Remember the flat camp. Remember flat. What is flat? Flat means you have FSH, LH, ACTH, and your TSH. Camp is your what? Calcitonin, ADH, okay, na? MSH, P for your PTH. Okay, na? Remember the flat camp. Okay, na? Next one. All the inhibitors, somatostatin, alpha 2 adrenergic, and your acetylcholine mainly M2 and 4 are what you are. It is your second messenger is your GI. It is your GI. It is your GI. Okay. See, GS means what? Is your stimulatory. Okay, na? GI means it is your inhibitory. Okay, na? So cyclic, see, it will increase the cyclic MP. This is decrease the cyclic MP. I think decrease cyclic MP and somatostatin, so decreases. Okay, na? Next one. See, IPG is your what? Remember, all are ra. See, TRH, GNRH, GHRH. Okay, na? I remember remember ADH V1 I1 resembles at I. Okay, na? Next one, remember here. The next important one is this one. Remember, this is the type is your which increases the CGMP, which increases the CGMP. It is going to be automatic. Remember the GANE, GANE, GANE. Remember, guanylyl cyclase receptors. Remember, it's ANP, nitric oxide. Okay, na? Next one is remember the tyrosine kinase. See, tyrosine kinase. Remember, try in. Remember, try mapping. Try mapping means your tyrosine secondary messenger signaling is your map kinases, and your hormone is your insulin. So remember, try mapping. Next one, remember JAK-STAT. Remember, see, Jago, see, Jago, wake up. So Jago means it's just Jack. Jago means whenever you're going to wake up, you're having the more more energy. So it's the growth hormone, prolactin, leptin, apo. Okay, now the examples of your JAK-STAT. Got it? Next question, study here underwent TURP for BPH. 1 hour later, he develops vomiting, ultrasensorium. This is going to case of your is your water intoxication. Remember, actually for the BPH, you should stop the surgery. You should stop the surgery within 90 minutes. Okay, na? Within 90 minutes, because later if you are going to proceed the surgery after 90 minutes also, it going to water ma, there is a water intoxication. Okay, now see, remember one thing. See, BPH, what questions they will ask you. Remember the first question. BPH is more common in elderly. They don't ask you what is the zone. Which zone is most common? Remember, this is your in the transition zone. Okay, na? In the transition zone, it is most common is your BPH. Most common is your BPH. In the peripheral, in the peripheral zone, most common is your prostate cancer. Remember, transition zone is very near to your prostate, to your ureter. Peripheral zone is very far. So tell me if there is a okay now, if there is cancer in the peripheral zone, will there any symptoms? No. So transition zone is very near. So that's why there is a symptoms in the case of your BPH. Got it? You will get the symptom in the BPH. Okay now. So remember one thing remember here. So what is the symptoms here? Tell me, see there hesitancy, dribbling of urine agency. Okay now. What is the main culprit? Main culprit your DHT. Okay now. Got it? Yes, next one. See, testosterone. Actually, see, testosterone is going to convert into what? DHT. Going to convert into DHT by the enzyme called as your 5 alpha alpha reductase. Actually, DHT is also important for the two. It is also for the growth of your prostate. Okay, na? Got it? So that's why see in this case, what happens, Amma? So there is an enlargement of the prostate. So if you are going to inhibit this enzyme, then obviously the size of the prostate is going to reduce. So that's why you are going to give the prescribe the medication size your 5 alpha reductase, that is your finasteride. Okay, now. So finasteride and dutasteride, because so guys, after giving these your finasteride and dutasteride, guys, it is not going to cure within 2 to 3 days or 1 week. It will require minimum 5 to 6 months for this one. So for this, guys, for the immediate treatment, guys, the drug of choice is going to be what am I your drug of choice is going to be your tamsulosin, tamsulosin for the symptomatic treatment. And if the patient is hypertensive and having the BPS, drug of choice is going to your prazosin. Okay, na? Next one, what is the surgery we are going to do? We are going to do the TURP. Irrigation fluid, we are going to use the isotonic glycine. Complication, retrograde ejaculation. Late complication, bladder neck stenosis. What is the three-way Foley we are going to catheter we are going to use for the post-surgery irrigation of the clot. Got it? So that is what you have to know. Next, coming to prostate cancer, I just said that most common type is variety is it is the adenocarcinoma seen in the peripheral zone. That's why it is a asymptomatic. It is asymptomatic. Okay, now it is asymptomatic. Okay, now next one, yeah, screening. Okay, done. Next one. What is the next important one here, Jivar? Yeah. Next one. From the prostate cancer, first one is the peripheral zone. Most common variety is the adenocarcinoma. It is the what it is what it is your adenocarcinoma. Okay. So tell you my eyes is straining. Okay. Next one. See, on the DRE, BPH is a firm and rubbery. Here it is a hard and a nodular. What is the score for the grading? Here it is your Gleason score. What is tumor marker? It is the PSA. Okay, PSA more than 20, it will indicate the what is a prostate cancer. Okay, na? Got it? Next one here, spread is your, it's not lymphatic, it is by your, it is by your heterogeneous. See, it is your hematogenous. Yeah. Sorry, it is a right there, hematogenous spread. Okay, na? Distant metastasis common to the bone. Common to the bone. Okay, na? Next one, ra. What is the for treatment, ra? Treatment, we are going to for the T for the stage T1A, we are going to do the DR, that is observation for follow up. We are going to do the DRE plus and also your tumor markers. Stage stage T1B and T1C and T2. If the patient is more than 70 years, then go with the follow up. That is DRE plus plus your tumor markers. Less than 70 years, you have to you have to go with the radical prostatectomy. You go with the radical prostatectomy followed by brachytherapy. Stage 3 T3 to T4 guys, go with the androgen ablation. Androgen ablation. Okay. So androgen ablation, we are having the LH agonist, which is your watama, your guserelin. The drug is your guserelin. Okay, na? So that's what you have to know about the prostate cancer. Okay, only the few points for the exam purpose. Okay. Okay. Next one here. This one is all about the important poisonings. Important poisonings for the. It will cover your psychiatry and your forensic medicine also. Okay, na? So this one first question is a reflex hallucination. Patient seeing red colors while listening to the FM radio flashback phenomenon. It is your what? What is the poisoning here? LSD poisoning. Okay, na? See cocaine. You will see what there is a magnus. There is a magnus of magnus syndrome or cocaine bugs or fornicates. Meaning something is what is crawling. Something crawling on the hair. Thallium, remember, alopecia, datura, all the D's. And what is the physiostigmin? Cannabis runs is your run smoke. It is a run smoke. It's the most common abused in India. It is going to your cannabis. Opium, you are having the triad, meiosis, depression, coma. Here, all the vitals will be golden. Remember here, for the opium withdrawal, there is yawning, rhinorrhea, diarrhea. Okay, na? Lead poisoning, Butonian line, basophilic stripling, raindrops, going arsenic poisoning, strychnine poisoning. Okay, na? Opisthotonus. Okay, na? Opisthotonus position and the rhesus sardosis is it is your watama, is your strychnine poisoning, which resembles to the tetanus poisoning. Next one, the diabetes. Diabetes, you have to know what is the normal values. Okay, na? What is the normal values? Got it? How to know the normal values, because in the exam they will give the values. They will give the values and you have to interpret. Okay, na? So you have to know this one. Next one, management of decay. Management of decay. First of all, what you have to do? Tell me why decay will occur? Because if there is anyone who is on who is on insulin who missed the insulin, okay, na, they will get the decay. See, and the long time fasting stage, those who are diabetic, they will get the decay. So for the patient guys, there is what am they will, yeah. For this patient, you will get the kusmal type of breathing and also your fruity smell of the breathing. Okay, na? It's okay, but here remember what you have to study about decay. For the here we have to read about the management of this. You have to read the management here. Tell me what is the initial step you have to do. You have to do the first of all you have to give the IV access, that is give the 0.99% of your normal saline. Then if the sodium is less than 135, continue NS. More than 135, switch to 0.45% of the NS. Then again look for the IV insulin. That is you have to always give the regular insulin. Regular insulin, check the serum potassium first before giving the insulin. If the potassium is less than 3.3, then give the insulin first. Okay, now there is a protocol, and then first of all we have to give the regular. Then if it is normal gas, then you have to give the subcutaneous insulin when the DKA resolves. Okay, now these are the questions you have to give. You have to remember about this one. So here, this is the answer is going to be what metabolic acidosis. So here, guys, acute your okay complaints of acute abdominal pain after see alcohol intake, pain related to the back. See, ALT, AST, amylase is also raised. This is going to your acute pancreatitis. This is your Turner syndrome. Turner's sign is going to your acute pancreatitis. Okay, now remember the acute versus pancreatic, chronic pancreatitis. So acute pancreatitis, remember what is the etiology? It is your gallstone. Chronic, it is your chronic alcohol uses. More common in males. Okay, now in the acute you will see the symptoms here: severe epigastric pain radiating to the back and relieved by bending forward. Bending forward increases on the lying supine. Nausea, vomiting. In the severe cases, the patient will be hypotensive. Here they will get the hemorrhagic pancreatitis examples. We are having the what your Cullen sign, Great Turner signs. These are the your hemorrhagic pancreatitis signs. Okay, now what is the investigation choice? CCT abdomen after 3 days. What is the score for the severity here? Ranson score. Most common complication, it is pseudocyst. It is pseudocyst. It is not lined by the epithelium, and in this case, it is lined by the granulomatous tissues. Treatment, you have to give the supportive treatment. You have to give the IV fluids, oxygen support, okay, and your symptomatic management. Chronic, it is a gradual and progressive, and it is a irreversible. It is a irreversible fibrosis and a calcification. It is your chronic is irreversibility, acute is your reversible. Here we have in the Tigaro classification. T means here this will be your metabolic, idiopathic, genetic, and idiopathic, genetic, autoimmune, and obstructive. These are the etiology. We are having the exocrine here in the exocrine pancreatic insufficiency and endocrine pancreatic insufficiency. Okay, in the exocrine pancreatic insufficiency leads to leads to decrease in the pancreatic lipase, amylase, which leads to a steatorrhea, because there is decrease in the lipase enzymes. There is a malabsorption, so this leads to steatorrhea. And the endocrine insufficiency will leads to diabetes. Got it? So here also we have to what is the gold standard treatment? Gold standard IOC is your ERCP. Here you have to treat the both pancreatic exocrine and endocrine insufficiency. Okay. Next one, for the acute pancreatitis, for the severity, we are going to use the BISAP score, and your QSOFA score. And also we are having the Apache 2 score, your Apache 2 score. Okay, just go ahead with this one. The most important one is the SIRS criteria. SIRS criteria already, it is a BISAP. In the BISAP, this is a BISAP, B for your burn, impaired mental status, S for SIRS. So what are included in the SIRS? Just go and this is a SIRS. Temperature more than 36, respiratory rate more than 22, heart rate more than 90, white blood cell count more than 12,000. Here the SIRS criteria. Next one, see this one. Yeah, see this one. Sudden onset breathlessness and short pain that increases on deep inspiration. She returned 2 days ago from a 14-hour flight. Oh my goodness, 14-hour flight and a swelling and pain in the cough. So this is going to DVT. So what is the most common diagnosis here? Tell me. It is going to what your pulmonary embolism. Pulmonary embolism most common due to your DVT. I think you guys know what to do. Just try to read this one. Read the management. Next one, remember this one. Blunt trauma and femur fracture. Okay. Lungs source feel clear, but patient remains confused. See here, see, this is the case of what mama. You are see, there is a history with a blunt trauma and a femur. There is a bone fracture. There is a bone fracture, and they will mention you there is a petechial rashes. It is case of what mama. The case of your fat embolism. Fat embolism. Okay, now next one. Tell me this one. Uh, Hypotension present with sudden onset, pleural effusion, breathlessness, worsening or line, examination, anxiety, tachypnea, bilateral basal, cough with pink frothy. Remember, pink frothy, pink frothy. You have to mark the answer as it or pulmonary edema. Okay, na? So this is the types of you have to know what is pulmonary embolism and fat embolism and your pulmonary edema. The differences you have to know. Okay, na? Just please try to read the questions carefully and you have to answer. You know. And also, guys, please, you have to know the few topics from the pulmonology, guys. You have to please pause the video and read about the asthma. Just read all my points, all my important points regarding the asthma, chronic bronchitis, emphysema. Yes, so this table is important. So, what is the example for centrilobar and the cigarette smoking is your centrilobar. Alpha 1 trypsin deficiency is your panlobar. For the blue bloater and pink puffers, which is for the emphysema and which for the chronic bronchitis. You have to know the differences. Okay, now remember this duration is important of cough with sputum with 3 months and two continuous years. This is your chronic bronchitis. So in this one, these are important 3 C's of your bronchial asthma: charcoal piston, Clusterman spirals, and clear bodies. Okay. Next one, this is important. So we see your bronchitis. Remember, clubbing is seen in bronchitis. It is in the bronchiectasis, but not in the COPD. Remember the clubbing B bronchitis. Okay, clubbing is seen only in the bronchitis. Okay, now just go with the read the points very carefully, and also you will see in the HRCT guys, you will see the there's a time track appearance. Also remember that also seen in the case of your lung is your bronchitis, MPGN, CRBU, and Sturge-Weber syndrome. And this is your pleural effusion. This is your pleural effusion. Okay, now pleural effusion, that is your Ellis score. This is the Ellis score. Okay, now next one, I think you guys know about this lights criteria. That's your lights criteria. Okay, now I think you guys know you have to know the transudate and the exudate. Okay, now you have to know what are the things included in the transudate. See, remember one thing. Remember one thing. Exudate. Remember exudate. When you see your X, then everything is going to rises in your body. That's why it is more than. Always it is more than. Everything is more than 0.5, more than 0.6. Okay, now more than 2/3. This is your exudate. This is your exudate. This is your exudate. Okay, now next one, see this one. See this one. See left one is normal here. This is the patchy here. This is the patch here. So this is your upper middle lobar. This is your right middle lobe pneumonia. Remember here fever, cough, inability to feed for 2 days. Examination chest in drawing is noted with respiratory rate 42. See chest in drawing noted, respiratory rate 42. Okay, there is no there is no there is no danger signs. Okay, na? she is not feeding for 2 days. Okay. So not eating for 2 days. So this is going to what am I? Your severe pneumonia. In this case, you have to put the IV fluids. So guys, this is the curve 65. This is the old one. It is replaced by your CRB 65. This is for the admission criteria. This is for the admission criteria for the for the pneumonia patients. Okay, na? So just don't read this one. Read the updated one. If they ask you CRB 65, then you have to mark. Then you have to answer according to this one. If they says according to cos 65, then you have to mark this one. That's why for me, guys, read both. Okay, na? Next is pneumonia, green zone, yellow and red. I think you guys know. Next one, anti-glaucoma drugs. Remember, anti-glaucoma drugs are very important one. See, ग्लाकोमा ड्रग्स इसमें क्या होता है? पानी भर जाता है, ठीक है ना? पानी भर जाता है, हमको क्या करना है? पानी को निकालना है, ठीक है? ग्लाकोमा पानी को निकालना है. सो पानी को निकालना है. इसमें क्या करना है? पानी को भी बंद कर दो, ठीक है? पानी को बंद कर दो, नहीं तो पानी को भगा दो, ठीक है? सी पानी को भगाने के लिए दिस इज डिक्रीज द एक्वास प्रोडक्शन, ओके ना? Which decrease the aqueous production. Aqueous production. Remember, B B C C, B B C C, B B C C. Say aqueous, B B C C, B B C C, B B C C, alpha agonist, B B beta blocker, C C carbonic energy inhibitors. Got it? See, beta blockers, timolol, betaxolol, cartiolol. Remember, betaxolol is actually timolol is contraindicated in the asthma patient. Then what is the drug of choice? Is going to be betaxolol. But remember also cartiolol is safe with the dyslipidemia patient. Got it? Next one is briminodin. Briminodin is contraindicated in the children because it causes the apnea. Next one is your carbonic energy inhibitors. Example your astazolamide, brinzolamide, and this comes for the what your eye drops. Okay, na? Next one is the which increases trabecular outflow is going to your pilocarpine. Pilocarpine is the drug of choice in the what acute closure angle glaucoma. Okay, na? Next one is a increase the uveoscleral outflow. See UVO. See remember UVO. See aqua BBCC BBCC. Uveoscleral increases uveoscleral outflow is going to what your lateral or prost. Uprost. Okay, na? Uprost means uveoscleral. Prost means all are your prostaglandins. So latinoprost, bimatoprost. I think you guys know latinoprost will causes the water darkening of your colors iris, which leads the what your increase the more iris. Okay, na? There is a more growth of your eyelashes. Okay. Next one, guys, you have to read about this one. Oxygen imperfecta, Marfan syndrome, EDS, and also read about the homocystinuria versus Marfan syndrome. Homocystinuria versus Marfan syndromes. Okay, na? Remember, everything here. What is the most common death here? I have to root dilation. Here, remember, it is what a complication. It is your thrombosis, vascular compression. Okay, na? Okay, just read about this now, because this is very short session. I'm not going to explain you everything, but you must know these are the important things. Okay, na? Every time you are getting the one MCQ from this slide only. Okay, na? Marfan syndrome पक्का आएगा, इसमें से आता है, सभी में आता है. Unit next one रहा central DI, nephrotic DI. Central DI means किसमें प्रॉब्लम है? ब्रेन में प्रॉब्लम, ब्रेन इंजरी, हाइपोक्सिया. नेफ्रोजेनिक किसमें प्रॉब्लम है? किडनी में प्रॉब्लम है. ठीक है ना. Just remember central DI, your desmopressin, it is your next one. Nephrogenic, it is your thiazides. It is your thiazides. Thiazides, okay. Next one, diabetic retinopathy. We have here two types: NPDS, NPDR, and a PDR. PDR means what? Proliferative means naya. Means there is a neovascularization. Neovascularization of the whatever vessels. Okay, na? Of your retina. Neovascularization of your retina. Here there is a formation of a micro aneurysm. There is a micro aneurysm. So there will be a dot and blot hemorrhages. Dot and blot hemorrhages. Remember, and here retinal detachment. There is three types. It is that is your rhegmatogenous, and traction type, and your executive type. Exudative type. Remember, if there is says that it is a curtain falling. This is the curtain falling. It is your in the history, for example, guys, in the history, if they says that there is a curtain falling, like, remember the answer should be your retinal detachments. Okay, na? Mark the answer as the retinal detachments. Okay, na? Actually, they don't give you like about about this. Okay, this is what type of detachment. They don't give this one, but remember, if there is a curtain, okay, curtain falling, it is a curtain falling, like, then it is going to be what my word, it is your retinal detachment. If you want to read, then read. But the most important one is they will ask you what is the curtain falling like appearance seen in the case of your retinal detachment. Okay, now in the examination, they will use this image and this image. They will ask you which one is the NPDR and the PDR. Next one is your lateral medullary syndrome and medial medullary syndrome. Tell me here. Tell me here, Ra. Okay, okay. I will explain this one. Okay, okay, see this one, Ra. Okay, this is a medulla. Yeah, yeah. This is a medulla, Nara. This is medulla. Okay, na? So, guys, tell me here from the midbrain pons medulla. From midbrain, we are getting cranial number 3, 4, pons 5, 6, 7, 8, medulla 9, 10, 11, 12. Okay, now see, cranial now 12 is medial. Is coming from the medial side. Coming from the medial side. Got it? And also see cranial nerve 5. Cranial nerve 5 is also the nucleus. The nucleus of the cranial nerve 5 is also coming from the middle side only. See here one thing. See here. Cranial number 5, 8, 9, 10, and 11. 9, 10, 11 are are lateral side. Are lateral side, isn't it? And okay, na? Lateral side. And your cranial number 12 is your medial side, isn't it? Medial side, isn't it? Okay, now see here, we are observing only medulla. So this is medulla. Okay, now see, we are not including the pons and midbrain. We are calculating only medulla. In medulla side, tell me here. This is okay, now see here, eighth one. Okay, now eighth one. See, eighth one in between the in between the medulla and pons. Eighth canal now in between the this is a pontomedullary junction. That's why I included the eighth one also. This is your 5, 10. Okay, na 5, 8, 9, 10, 11, 12. Okay, and next one, this is your corticospinal tract. Next one is your dorsal column tract, and the last one is your STT, spinothalamic tract. Okay, now so guys, Corticospinal tract, what is function for the motor function? Dorsal column for that fine touch. Next one here, spinothalamic tract is for your what for the pain and temperature. Okay, na? Remember, if there is anything cranial nerve related, if there is anything cranial nerve related lesion, then everything is going to your ipsilateral. Everything will be ipsilateral. If there is any tracks letter is going to a contralateral. Okay, na? Remember, you got it up. Okay, na? 12 medial side. So see your corticospinal tract and a dorsal column. These two are see the dorsal column is also called as your medial lemniscus. Okay, now see corticospinal tract and dorsal column. These two are what am your at the middle side. Which is one lateral side? Remember STT S for sides. Are side please. My outlook. See spinothalamic tract side lateral side. Okay, now so tell me what happens in the medial medullary syndrome. Tell me in the medial medullary syndrome what happens. Tell me in the medial medullary syndrome. In the medial medullary syndrome there will be what lesion to what this one involvement. There is a involvement of your 12th cranial nerve and your corticospinal tract and your dorsal column. So remember what is the 12th cranial number? Hyperglossal. So there is a what there is a deviation of your there is a ipsilateral deviation. Tell me this is the medial one. So there is what tell me this is the see very easy. Next one CST. There is a contralateral hemiparesis. Next one dorsal column, contralateral loss of your proprioception. Wow. See, okay. So the measure here, the most likely measure involved is your in the medial is your anterior spinal artery. In the lateral, most common involved is the pica. So like this only if you are going to like this only, if you are going to correlate here, lateral one is going to 5, 8, 9, 10, 11. These all are ipsilateral, and your CS and your STT, spinothalamic tract, is also your lateral side. It involves in the lateral medullary syndrome. So STT, there is a contralateral loss of pain temperature, contralateral loss of pain and temperature. Okay. See, pain temperature contralateral. Okay, na? Okay. Next one. Fifth cranial, there is a what it is your trigeminal, there is a face loss. There is a sensation of the face. Ipsilateral is by your fifth cranial nerve. Okay. Dysphagia, vertigo, eighth cranial nerve. Okay, na? Hoarseness of voice, 10th. Okay, na? So these are symptoms of your lateral medullary syndrome. Okay, na? So guys, lateral medullary syndrome is also called as your lateral Wallenberg syndrome. Middle is called as your D-journey syndrome. Okay, na? So this is the whole things. If you don't remember, just remember, don't pick a lame horse that can't eat. Don't pick. See, don't pick means it is your what is pick means pica. This is your posterior inferior cerebral artery. Lame means what means lateral medullary syndrome. Can't horse means hoarseness. Can't eat dysphagia. Okay, just remember that. If you don't want to remember like this, then remember like this. Okay, so this is the image you have to remember. You have to mark. So this is your what is olfactory. All the cranials are important. Just you have to know the labeling is important. Okay, na? This is your Brown Sequard syndrome. Just remember OPT. OPT. Remember opposite side pain and temperature. There is a loss of opposite. There is a loss of opposite side There is loss of contralateral pain and temperature. Loss of contralateral pain and temperature in the Brown-Séquard syndrome, and everything is going to be ipsilateral. This is your Brown-Séquard syndrome. Celiac disease, everyone know this one. Celiac disease, very important. Next one, I think you guys know this one. Main 1, main 2, main 3. Leave it. Just know just you have to by heart this one. Cone syndrome. Just remember in the Cone syndrome, these are the important. What are the findings here? Hypernatremia, hypertension, no edema. Here, no edema. Here, remember, no edema here. All are making mistakes here, which is no edema here. Okay, na? This is your next one. Okay, na? Okay. Cone syndrome done. Next one is here. Addison disease is important. Addison disease is important. Addison disease, there is a what amma? There is more ACTH. There is more ACTH, which leads to what amma? Your hyperpigmentation. Here ACTH is high and everything is going to low. Here in the cortisol will low, aldosterone low, sex drive is low. In the case of your Addison disease. In the Cushing disease, in the Cushing syndrome, cortisol will be high, ACTH will be low. So cortisol will be high. Tell me, all the peripheral fats, what happens? It will come to central part. So the patient will look like moon face. Then it gives the moon-like faces, and there is a lemon strings appearance in the case of your Cushing syndrome. Okay. Yeah, so this is, you have to know, this is your action potential. That it is by here. This is the sodium influx, potassium efflux. Okay, na? These are the ECG. These are the EEG waves. You have to know. Okay, na? Awake. Remember, it is a beta wave. Just remember, awake. Beta, utho. Awake means a beta waves. Okay, na? In the NREM, guys, we are having stage 1, stage 2, stage 3, and REM. It is like a paralysis. REM is like a paralysis. Okay. Just remember this one. Ra. Okay. So, guys, this is your JVP. I think everyone knows this one, JVP. So, okay, na? I don't want to discuss this one, but I will discuss the important points. Okay, na? Chronic encephalopathy except here confabulation. Confabulation is your Korsakoff. See on the JVP, remember JVP, they will always test you guys. So this is your, okay, this is your, what is the diagnosis? Your cardiac tamponade. That is your cardiac tamponade. Okay, isn't it? Muffled voice, okay, muffled heart sounds, hypotension, these are the cardiac tamponade. In the cardiac tamponade, what is the diagnosis here? There is absent Y descent. It is the absent Y descent. It is absent Y descent. Absent Y descent. Can be seen in complete heart block. Remember, complete heart block. Whenever there is a heart rate is less than 100, mean bradycardia, then only it is a whatever your complete heart block. Tachycardia, it is your PSVT or ventricular tachycardia. Absent waves in the case of atrial fibrillation. Large waves, tricuspid stenosis. Okay, now next, constrictive pericarditis, steep X and steep Y descent. Just remember these cases. Okay, now see here. See absent Y descent. It is your cardiac tamponade. See steep X and absent Y. Remember, absent Y is cardiac tamponade, and steep X and absent Y also it is your cardiac tamponade. But if there is a both steep X and steep Y descent, it is by your, it is here in the case of your constrictive pericarditis. Your constrictive pericarditis. Everything is your calcified here. Okay, now so steep X and steep position, steep X, steep Y, steep X, steep Y. In the case of your constrictive pericarditis. I think you guys know all this one. Okay, na alcohol withdrawal. Okay, na delirium. Okay, na next one is a is a universal fact. One is encephalopathy, Korsakoff syndrome, and dry berry, wet berry. Okay, na dry berry. We'll see the what polyneuropathy, wet berry. What are the symptoms? Cardiac failure. So for the exam point of view, these two are important. These two are important. Next one, this is the case of your still high. This is the case of your ectopic SCTS secreting tumor. Okay, this is the case of your stomach Cushing syndrome. See here, see in the Cushing suspected, remember this one, we are going to do that some test to diagnose the whether it is a Cushing disease or Cushing syndrome, or if this is going to be what, or is there any associated with the small cell carcinoma. Okay, na? Actually, guys, see here, what is the most common cause of the Cushing disease? It is your iatrogenic. Iatrogenic is the most common cause. See, screening. Actually, guys, whenever you are going to give the dexamethasone, then what happens? The levels of the ACTs will be low. Okay. See, what is the screening test of choice? It is 24 hours cortisol level. 24 hours of cortisol level. Whether this is it is increased. This is normal. Okay, na? Whenever what is the investigator, see, whenever they will ask you guys what is screening test of choice, 24-hour urine cortisol level. Investigation of choice is going to your low dose dexamethasone test. Low dose dexamethasone test. For this, guys, you have to check the ACTS levels. To differentiate between the why we are doing this one, we have to differentiate between the whether it is iatrogenic or pituitary tumor or lung cancer. Okay, so Cushing syndrome, it is due to iatrogenic cause, pituitary cause, or lung cancer. So this is, remember, if the ACTH is low, then it is purely going to be a iatrogenic cause. If it is high, then we have to suspect it is whether if the pituitary tumor or lung cancer. Okay, na? So in this case, we have to give the high dose suppression. You have to do the high dose suppression test. See, after doing this, if it is low, then it is going to what your pituitary tumor. If it is still high, then it is your ectopic. It is your ectopic. Meaning this is ectopic. This is going to what means it is associated with the small cell carcinoma. Got it? So remember, first of all, you are going to do the low dose test. If the ACTH is low, then it is heterogenic cause. If it is high, two causes: pituitary tumor, lung cancer. To differentiate between the which is tumor or lung cancer, you have to do the high dose test, high dose suppression test. If it is low, it is your pituitary tumor. High, if it is still high, then you have your ectopic cancer. Okay, ectopic ACTH, that is associated with the lung cancer, which is small cell carcinoma. Next one, very simple, very simple. Acute means what, amma? Remember, IgM means what, amma? Acute. IgG. Okay, sorry. See, IgM what, amma? Acute. IgG chronic. Okay, na? Just remember this one. Okay, this is the case. This is your fistula. This is occurs after your what, amma? Hysterectomy cases. Remember what they asked here. Diagnosis if the middle swab is stained with dimethylene blue 3 swab test. Okay, na? See, they asked you middle swab. So this is the middle one. This is what this is your ureter, this is your bladder, this is the urethra. Ureter, bladder, urethra. So what they asked here, third middle swab. It is your bladder. Bladder is what vesicular-vaginal fistula. Okay, na? So remember one thing that we having three types. First one is the ureterovaginal. If there is connection between ureter and the vagina, if there is a connection between ureter and the vagina, what happens? Tell me. There fistula between the ureter and the vagina. Whatever the urine coming from the kidney, to the ureter, it will goes to the urine, it will goes to the vagina. So there is a continuous dribbling from the vagina. Okay, na? Continuous from the vagina, but and also some little amount of urine will come to the bladder also, but there is a no problem with the urine flow. What is next one? But only problem is the continuous dribbling of urine. Vesicular-vaginal. Tell me, vesicular-vaginal, when there is a connection between the bladder to the vagina. Tell me what happens. All the urine from the bladder, it will comes to vagina. So there is always what, Amma? There is always there is a no normal urination now, because all the urine is coming towards the vagina. So there is always empty now. So there is no normal urination. Urethra-vaginal, please tell me. Urethra means what, Amma? So see here the urine, here bladder, we pass urine when the bladder is full. What it? So tell me here. Actually, so for example, here the bladder is full, but there is a fistula between the urethra and the vagina. Is there any continuous dribbling? No, because there is a fistula at urethra. That's why there is no dribbling. When there is dribbling, whenever the patient will go to toilet, what happens? The urine from the urethra is going towards the it is going towards the vagina also. At the time of when the patient is go for urination, that time only there is a dribbling. Okay, so case of your what this first class. Next one, everyone knows this one. This is a Lippus loop. Okay, copper T380 Mirena. Nephrotic. Okay, see this one, nephrotic is very, very important. Okay, see nephrotic. So you guys please read this one. Okay, na? I don't want to type to. I think you guys already know this one. Okay, so first of all, you have to know the nephrotic syndrome. Nephrotic syndrome, what is the definition? Urine protein, spot urine protein, and spot urine protein and creatinine ratio. It must be more than 2. It is going to what? Nephrotic. Urine protein more than 1000. Spot urine proteins more than 40 milligrams meter square per hour. So remember what is the drug of choice? Is got prednisolone. Prednisolone 2 milligrams per kg per day for the 6 weeks. First of all, what you have to give? Give the prednisolone 2 mg kg per day for the 6 weeks. And later we have to shift. You have to taper the dose. You have to give the 1.5 milligrams kg per day for the alternate days for the 6 weeks. Remember the whatever treatment, prednisolone for the 6 weeks. Next 6 weeks, 1.5 milligrams alternate days for the 6 weeks. Duration is just total duration 12 weeks. If it is steroid dependent, you have to start with the levacimab. Steroid resistant cases, go with the cyclosporine. Nephrotic syndrome, what is the most common causes in the children? Is going to your minimal change. It's for minimal change disease. Just read what is the minimal change disease here. PSGN versus IgA nephropathy. Remember IgA nephropathy. Remember the given history. If it is happens within 1 to 2 days, 1 to 3 days, it is going to be IgA nephropathy. If it is occurs within 2 to 4 weeks, then it is going to what PSGM. Na? So remember, see FSGS is most common in the where in the adults type. Read the question. If they give us the history as to HIV, mark the FSGS. Conjugate and what says unconjugate bilirubins. Just read the disease about this one. Okay. Next one is a breast one. First one is the fibroadenoma. This is a mammography. Okay, this is the mammogram. Popcorn calcifications here. Fibroadenoma most common in the 15 to 25 years old. What is the treatment here? Conservative and also for the most common for the cosmetic indication, we have to go for the surgery. Okay, which is called a giant fibroadenoma. Whenever it is more than 5 centimeters, it is called giant fibroadenoma. Paget's disease, whenever this is a eczema, there is a unilateral eczema-like condition. Paget, unilateral eczema-like conditions. Phyllodes, there is what cystosarcoma phyllodes. Okay, it is also called as cystosarcoma phyllodes. It is a more benign. Okay, it is rapidly growing breast mass, superficial, mobile, and skin color changes due to pressure necrosis. Skin color changes due to pressure necrosis. They are the simple question. Example, you have to do the mastectomy. Next one, next breast engorgement. Everyone knows mastectomy is okay. What is the treatment choice? It is your decloxacin. This is the drug of choice. Cloxacillin or decloxacillin is the drug of choice. Remember, if there is a discharge, bloody discharge, mark the answer as duct papilloma. Serious discharge, fibrocystic disease. Greeny discharge, your duct ataxia. Breast abscess, just read this one. Okay, remember, staging is very, very important. Remember T4A, T4B, T4D is very important. T4D is the inflammatory causes, inflammatory cancer. T4A, there is the involvement of the chest wall. T4B, whenever involvement of the skin, involvement of the chest, T4A. T4B, involvement of the skin. T4D is for the inflammatory cancer. Okay, na? Remember these questions. Okay, see here, lobular carcinoma. What is the pathology? It is the Indian file pattern. It's in the Indian file pattern. It is due to what loss of E. calorie. Just remember this only, and the invasive breast cancer. Okay, you want to be. Remember, in the pre-menstruation, you have to give the tamoxifen. Post-menstruation, you have to give the what is your aromatase inhibitors. One-liners, please read this one. Next one, okay, I'm going to skip this one. You have to read about the thyroglossus cyst, Ludwig angina, branchial cyst, cystic hygroma, and thyroglossus fistulas also. You are okay, expecting one MCQ from here. Next one here. See all the pumps are primary active, are the primary active, and all the symptoms are your secondary, are the secondary active transport. Okay, na? Okay. It's a passive diffusion. Simple type, there is no carrier required. Facilitated type, there is a carrier protein requirement. There is a facilitated carrier protein required, but no ATP. Example are for glue transporters. Okay. Next was muscle physiology. You have to read this one. You go to the YouTube and try to listen for that 10 to 15 minutes, and also try to open your notebooks and read the questions. Okay, na? From my side, just remember the muscle physiology. You will get the 2 MCQs, because I can't explain this here. This is going to be very, very lag here. This is other name and the location of the macrophages. The CNS is called as your microglia. Okay, this is the and guys, this is the Broca's and Wernicke's aphasia. This is the universal fact. Everyone know this one. So Broca's aphasia is the focus. See, next one, all the important nerve injuries are important. Here it is the loss towards the lateral aspect of the forearm. This is going to your muscular cartilaginous nerve. Sometimes they will give this type of images and they will ask you what is the nerve innervations here. Remember some example, nerve injuries here, wrist drop, foot drop, everything. You have to know this. Pause the video and learn. Myopia, hypermetropia, astigmatism, they will give the images. Okay, they will give light falls in front of the retina. The myopia, light will falls behind the retina. Hypermetropia, there is a multiple rays, more rays on the retina. Okay, they will give the images and also they will ask you the what is the treatment. Okay, this is your lambda sign and your what is your T sign. Lambda sign, T sign. So remember the lambda is your DD, lambda DD, lambda DD. See, you just remember a lambda. This remember lambda DD, DD, DDG, DD, lambda DD, lambda DD, and this is a MD, Modi. Remember just remember Modi T seller. Modi is a T seller. So Modi means MOD means monochronic diamagnetic is the T sign is the Modi. DD lambda sign. Okay, na? Lambda sign T is a T sign. Remember one thing, you have to remember the splitting occurring. Splitting occurred within 72 hours DCDA, 48 days MCDA, 8 to 12 days MCMA, more than 30 days is your congenital. Remember the 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 delivery of the twins is decided by the first fetus. First of example, it is vertex, then it is then the both delivery is going to be a vaginal delivery. If it is first one is the breech, then the both is going towards the LSCS. Okay. So these are some important about the psoriasis you have to remember. Okay, na? The important points you have to remember. Okay, na? There is a aspect sign positive. Corbinate phenomenon is positive here. Okay, na? Just remember that. Pustular psoriasis, lack of pustules here, and this is your gutter psoriasis. What is the treatment here? This. So these are some important phenomena. So no, Kibness phenomenon. Remember the pneumonic Pallavi, PSV, lichen, psoriasis, lichen, and vitiligo. Pseudo-Kibness reaction, leprosy type 2 reactions. What type of hypersensitivity reaction? This is positive Nichols sign, pseudo Nichols sign, false Nichols sign, cerebriform, tongue, and aspect sign positive in the psoriasis. Just pause the video and remember this. These are all the important signs. Guys, remember about the Retter syndrome and Alport syndrome. This is your whatever lacy reticular variant. It is a CRT bodies in the case of the lichen planus. Yes, so what's guys you have to remember? Remember about the pemphigus types. You have a pemphigus foliaceus and a pemphigus vulgaris. Pemphigus foliaceus, remember this is the word desmoglein 1. Vulgaris is your desmoglein 3. Okay, na? See, pemphigus foliaceus, they will give the history. There is a skin lesions. Okay, na? Skin lesions, and there is under pemphigus vulgaris. There is a lesion at the mouth. No skin involvement in the pemphigus vulgaris. Just remember this one. And guys, this is the everyone know this one. What are the layers pierced during the lumbar puncture? I think everyone know this one. Okay, leave it. And these are the important. This is the important image. You have to remember. Okay, this is the two lateral ventricles here. This is the fornix here. Okay, this is your what is this, Amma? This is this one. Okay, this is what you have to. This is your corpus callosum. Okay, corpus callosum. Okay, now body of the fornix. So hippocampus. See everything. This is your internal capsule or internal capsule here. Okay, now see everything. You have to pause the video and try to just mug up this one. Okay, just mark up this one. See the exact, okay, na? The exact image will be given in the exam, and they will ask you to mark this. And so, what is this? This is going to be your internal capsule. This is your internal capsule. Okay, na? 13th one, see here. This is your globus pallidus and the globus putamen. Okay. Next on the same one, they will give this image and ask you what is the nerve supply and what is the parts and so on. And also this is the MRI brain. They will ask you, okay, no, what is this part and what is this part. Okay. Tumors, guys, CNS tumors in the children and the adults. You have to read by your own. Okay. So in the exam, they will give the MRI image also. Please try to correlate with the MRI images of the, okay, MRI head images also. Okay. Just pause the video and try to read this one. Next one, the sleep apnea. See here, I will tell you one thing. One thing here, tricky one. Okay. See, sleep apnea. Okay. Yeah. Obesity here. Obesity, hypoventilation. Obesity, hypoventilation syndrome. In this case, they will give the ABG. They will give the ABG values. They will give the ABG values. Okay. Na? If they give the ABG values, then they will ask you what type of apnea, sleeping syndrome, sleeping disorders. Just remember, right? It is going to your obesity, hyperventilation. Remember, they will give the ABG values. They will give the ABG values that mark the answer as your obesity, hyperventilation syndrome. Okay, na? Remember. Next one, this is from your pathology. This is from the pathology, guys. So okay, this is the calcium is normal. This is your dystrophic calcification. This is your dystrophic. Just remember the dystrophic versus metastatic calcification. This is very, very important. And also, guys, remember most potent chemotactic factor for the neutrophil is going to be what? C5a. Okay. Just remember the cellular events. Remember the mnemonic is the MATCOP. First one is what? Migration, rolling, adhesion, transmigration of the diaphysis, chemotaxis, and opsonization. Just read this one. Okay. Next one, okay. Okay, this one, NBT. So NBT test is negative. This is going to what? Chronic granulomatous disease. And this one here, partial albinism. This is a partial albinism. And this is the case of what? This is the case of your celiac. This is the case of celiac Higashi syndrome. Absent mature B cells and absent mature B cell marked disease. So this is going to your all of BBB. So it's a Bruton. Just remember, this is the questions they will ask you from here. The most important one is the chronic granulomatous disease. Defect is the NADPS oxalate deficiency. Okay, na? This question they will ask you for sure in the exam. One MCQ for sure. This one from the next Bruton's agammaglobulinemia. Here, this everything is going to be BBB. Seen in the boys, B cell defect, BTK gene defect here. Okay. Celiac Higashi disease defect in the Y, list gene defect. Okay. Okay. So these are some important syndromes, and you have to know what is the cardiac abnormality in the hemophilia A and B type. Most sensitive in SLE. Most sensitive is ANA. ANA is always sensitive. Most specific is your ASA. Okay. Okay, guys. So this is what is in this is the Melkerson syndrome. This is the Melkerson syndrome. Okay, na? This is a Melkerson syndrome. There is a what? There is a recurrent oral. There is a recurrent. Bell's palsy. There is a recurrent Bell's palsy and a fissure tongue. Case of your Melkerson syndrome here. This is your these are the complication of your breast cancer surgery. Okay, this is the angiosarcoma, lymphedema. This is your okay. So this is your safety muscle. It is your posterior cricothyroid muscle. Just remember that sometimes they will ask you what is this muscle. This is your Pringles maneuver, guys. So for doing the before surgery to stop the bleeding. Start the bleeding from the portal vein and the hepatic artery. Okay, got it. Thank you so much, guys. So this is the very long session I have taken. So okay, guys. So these are the important points you should master, guys. You should master for the exams. Okay. I think it might be bored, but you have to. Okay. Thank you very much, guys. Bye bye. See you.